In that spirit, tonight I make a special request. Please turn to your neighbor and say hello, your neighbor to the left. Hello, Mr. Foster. And turn to your neighbor on the right and say hello, Bruce Lamoureux.
Nice to meet you, Tara.
This simple act will help encourage a sense of community as we discuss this important topic. Ladies and gentlemen, we're on a roll. By the end of the night, you might see hugging break out on the stage. Mark this moment. All right. I thank our co-sponsors for this event, the Alaska Humanities Forum and the Anchorage Public Libraries. I also thank the Alaska Common Ground board members and volunteers who helped put this event together. If you like what we're doing tonight, feel free to make a $10 donation at the door, at the table if you haven't already. This is the third of 5 events Alaska Common Ground is holding on the issue of our state's high healthcare costs. This series examines the difference between the U.S.'s high healthcare costs, which are the highest in the world of any nation, and Alaska's high healthcare costs, which various studies have shown to be the highest of any state. This event tonight examines the factors causing that difference. Like the rest of the events in the series, this event will zero in on the cost of healthcare, which is, of course, different from, although related to, the cost of health insurance. Unlike other events in Alaska Common Ground's series on our state's high healthcare costs, this event concentrates on the causes of those high healthcare costs in our state, not the consequences or the potential solutions. We will have events regarding potential solutions Wednesday evening, January 10th, and Wednesday evening, January 24th. I invite you to each of those events coming up next month right in this room. This evening, each of the 7 panelists will give an introductory statement of no more than 4 minutes, setting out the panelists' views of the causes of Alaska's high healthcare costs. And although you must admit this is a pretty cool event, it's organized. More organized than you think. We even have a timer that our treasurer, Dick Milius, treasurer of the board of Alaska Common Ground, that fine man in the front row holding up the cards, is actually timing. So we're going to start with each of our panelists giving a statement of up to 4 minutes in length of what they think are the causes of Alaska's high healthcare costs. I'm going to start with the man immediately to my right, Bruce Lamoureux of Providence.
Thank you, Cliff. Good evening, everyone. Thank you. I'm Bruce Lamoureux. I serve as Chief Executive for Providence Health and Services Alaska. I wish to thank Cliff and Alaska Common Ground for the invitation to participate in the dialogue this evening. I welcome the opportunity to contribute to our shared understanding of what's happening in healthcare, which is a complex issue, as everyone knows, or most everyone, right? I represent Providence, Alaska Medical Center, as well as the other portfolio services in Alaska. So the critical access hospitals in Kodiak, Seward, and Valdez, long-term care, assisted living, joint ventures, including flight ambulance. So a full portfolio of services. I'm not representing the hospital industry. While I can speak to some of the issues, that is not my role this evening. And certainly, if you hear nothing else from me, you should hear that hospitals, in fact, as is painfully obvious, are part of the problem as far as high healthcare costs in Alaska. I encourage your attentiveness and clarity as all of us engage in dialogue and begin talking about the charges in healthcare, the pricing of healthcare, reimbursement, and costs. Those are very different issues, and depending on the perspective from which a speaker is offering commentary or posing questions, it may mean something different in each instance. So the higher costs of care in Alaska compared to the Pacific Northwest are driven in part by some of the following. There are the usual suspects: labor, utilities, shipping, facilities, the things that all of you are acquainted with no matter the industry you serve in. There is also something that is a little more unique in Alaska, and that is the insufficiency of post-acute care patient placement options. And by that I mean, just because someone who is sitting in an acute care inpatient bed is deemed no longer meeting criteria for acute continuation of acute care does not mean there is a place to send that individual. They may be homeless, there may be really a multitude of issues involved. So that's an issue. In other markets, there is more in the way of post-acute care accommodation, and so that diminishes the cost of care when available. Other circumstances and or services that are unique to Providence, Alaska Medical Center, the largest acute care facility in Alaska, it is essentially the county hospital, among other things. So if you're in Los Angeles, Seattle, elsewhere, there are county hospitals. We don't have that in Anchorage or Alaska. And so by default, Providence, Alaska Medical Center is the county hospital. We have services where there is insufficient demand to justify or attract independent physicians to come into the community and provide service. And so in those instances, Providence, Alaska will employ a number of physicians in order to create both income streams for the individuals and life practice balance that is reasonable for them. We instituted a senior care clinic in response to community needs. We have a trauma center for both adults and pediatrics. Not every hospital has that. Most do not. We are a disproportionate share hospital, which is a designation identifying institutions that take care of a larger than average number of patients with lesser reimbursement. And going back to the issue of insufficiency of post-acute care patient placement, through August of this year, Providence, Alaska Medical Center has had 2,700 days plus of uncompensated care. So patients sitting in beds for which there is zero reimbursement. That drives up the cost for others. So with that, I'm going to give whatever few seconds I may have left to others, and then anticipate your questions and commentary later in the program.
Thank you, Mr. Lamoureux. I want everybody else to know that after we have this period of introductory statements from the panelists, and the panelists question each other, we're going to have questions from the audience on 3x5 cards, and or even larger, is held up by Teresa. So make sure that you look for a 3x5 card if you want to get a question in.
There's a lot of brain power in this room. I expect questions.
All right, thank you. So our next panelist is Dr. Robert R.J. Hall, who's an orthopedic surgeon and leader at Orthopedic Physicians Alaska. Dr. Hall.
Okay. So for those of you who don't know me, I'm R.J. Hall. I've been practicing here in Anchorage for orthopedic surgery for the last 22 years. So I've seen a few things. So, but I don't want to promote myself as a healthcare cost expert, but I actually have reviewed data on healthcare costs over the last few years. I've served for several years on something called the Medical Services Review Committee. We advise the State Workers' Compensation Board on the work comp medical fee schedule. So over the last few years, our committee has reviewed a large amount of data regarding costs in almost all areas of healthcare, whether it's physicians, hospitals, drugs, PT, air ambulances, anything you can bill for, we've looked at it. So some of the things that we found, probably the main point that I would say is good data on healthcare costs is actually really hard to come by. Because it's so hard to come by for certain areas like private insurance, our committee has actually paid several vendors for data, both for work comp insurance and commercial insurance. Everybody's data is a little bit different. Private insurance data is especially hard to come by. Nobody's required to report any of this data, so most people don't. The data that gets used is usually some small subset, and you don't really know how representative it is. Absent something like an all-payer claims database, we probably won't ever have a totally accurate view. I think like 14 states or something have that. Second, to state the obvious, costs are higher in Alaska, and pretty much this is across the board, not just physicians and hospitals. In general, what we have seen is that prices for services haven't necessarily gone up all that much. They just haven't gone down like they have everywhere else. I think a lot of that in Alaska has just been more inertia than anything else. For the last 2 years, we've made reductions in the work comp medical fee schedule. These reductions have been in all the areas to various degrees. During public testimony and correspondence that we received, I would say that pretty much all groups recognize that costs need to come down and are willing to accept that. The vigorous discussion is by how much, and of course everybody's in favor of the other guy cutting his costs. What everybody also agrees is that there's a lot of cost shifting going on. Hospitals and providers provide the indigent care, like Bruce said, and the trauma care for free, except it isn't free. The private insurance patient is helping pay for that. Many clinics couldn't afford to see Medicare or Medicaid patients unless they have enough private pay patients. Like Bruce said, a lot of these things are paid for differently in other states through other mechanisms, through state or federal subsidies, i.e. taxes, not through insurance. In Alaska, private insurance pays a share of pretty much everybody else's health care, and we are not paying state income taxes. I'd make a couple other observations as somebody who's been around practicing for a while. One, there's a lot more spending on healthcare in Alaska these days because there's a lot more healthcare available. There are more specialists in the smaller towns, more subspecialists in the bigger towns, more facilities. When I came up here, people used to travel outside and didn't think about it. You travel outside for care. But now people can get services here that they didn't used to be able to get. Now more dollars are being spent in Alaska that used to be spent outside. And then also, when I first came to Alaska, I worked with the old A&MC down 3rd, downtown, if you've been around long enough to remember that. Orthopedic surgeons at that time, we were the highest paid doctors, and we made $80,000 a year. If you drive down Tudor Road these days, you can't help but notice that things have changed in the native healthcare system. Back then, it was an IHS facility funded almost entirely by federal appropriations to the IHS. But back in the 90s, the native healthcare system started billing Medicare, Medicaid, private insurance. Now 40% of Alaska Medicaid spending goes to native healthcare, with a state Medicaid budget of about $1.8 billion a year. That's an additional $700 million a year just in Medicaid being spent in Alaska that didn't used to be spent here. And that's not a criticism of the native system at all. They're doing a great job, and I don't want to have that misinterpreted. Alaska has some unique challenges in delivering health care, and we do have higher prices in the private insurance segment, but I think overall we're experiencing the same healthcare cost crisis that everybody else is. You can hear healthcare horror stories in any state. Healthcare spending is on an unsustainable trajectory everywhere, not just in Alaska. So we'll see tonight if anybody else has got a great idea.
Thank you, Dr. Hall. Now we're going to turn to another orthopedic surgeon, Dr. Alan Groh. Dr. Groh, could you describe, 4 minutes or less, your views on the causes of Alaska's high healthcare costs? Also knowing if you don't get your questions answered tonight, come see these people, buttonhole them, maybe even offer to buy them a beer. You'll get maybe even more out of them. Dr. Groh.
Hi, I'm Al Gross. I'm the orthopedic surgeon who's been in the news a lot, so sorry about that. We're here to discuss why healthcare costs are so much higher in Alaska than in the rest of the United States. Premiums in Alaska are triple the national average, and it's not a lot more expensive to practice medicine in Alaska. In fact, practice and hospital overhead are approximately 30% higher than down south at most. The reason why healthcare costs so much more in Alaska is because prices have escalated to very high levels. So it's prices, not the costs, that we're talking here. When you look at the data, you'll see that it's not because of higher pharmaceutical prices in Alaska, It's not because of higher insurance company margins, and it's not because of higher medical malpractice rates. These are all pretty similar to down south. What stands out is that physicians and hospitals are paid a lot more than for their services down south. It turns out that hospital charges account for approximately 42% of our healthcare dollar, and physician services account for approximately 30% of each healthcare dollar consumed in Alaska. And 80% of healthcare insurance reimbursements to physicians in Alaska are being paid to specialists, 80%. And in Alaska, specialists are reimbursed anywhere from 2 to 5 times more than the national average compared to their colleagues down south. And by specialists, I mean anywhere from radiologists, dermatologists, virtually all types of surgeons, pretty much everyone except for primary care. Primary care physicians in Alaska are reimbursed about 1.5 the national average. So clearly, this is not a primary care problem in Alaska. Hospitals in Alaska, on the other hand, have margins of 3 to 4 times the national average. And considering their market share, this accounts for a great deal of money as well, more than the physicians. I believe historically that there are 3 major reasons as to why specialists in Alaska have been able to charge so much more than our colleagues down south. First, we are very geographically isolated. Second, monopolies have been allowed to form, essentially killing any form of competition. And thirdly, we have in place an insurance regulation, the 80th percentile rule, which we'll hear more about tonight, which has allowed specialist fees to rise without restraint for a long time. This is capitalism in healthcare, not malicious greed. This has nothing to do with whether a physician is a nice guy or not, or a good physician or not. With respect to hospitals, there's no managed care in Alaska, which has been shown to bring down costs to consumers considerably down south. Legislation in the 1990s has prevented managed care from penetrating into Alaska. There may be other reasons as to why hospital charges are so high, and I'm hopeful that Mr. Lamoureux can honestly address those. This is clearly not just a Juneau problem. This isn't a personal problem. You can attack me as an individual, but really this is a statewide problem. If this was just a Juneau problem, you wouldn't all be sitting here tonight. And the big problem is that the consumer, people that buy healthcare, are getting a really bad deal in Alaska. Wealth inequality has been a hot topic in America recently, and while I'm a big believer in free market capitalism, healthcare in Alaska, at least with respect to specialty and hospital care, there is no free market, and with third-party payers increasing their payments to providers and hospitals almost without restraint up until recently, the consumer has had very little to say in the process. And this is what happens when you have monopolies and third-party payers in healthcare. While so many specialists have recently signed on as in-network providers, they have signed on at rates that are still much higher than the national average, much, much higher. Access and cost of healthcare is the #1 issue in our country right now. And in Alaska, the economy can't sustain these high prices anymore. We need to find a better model for healthcare delivery, such as a single-payer system, which would rectify our aberrant billing system and would cover everyone for a lot less money than we're currently spending today. Thank you.
Thank you, Dr. Groh. We'll have whole sessions in January to go to the solutions. And now we're going to turn to Dr. Stanley Watkins, a cardiologist and leader at the Alaska Heart and Vascular Institute. Dr. Watkins.
Thanks. Thanks, Cliff. Thank you so much for putting this together and giving us an opportunity to speak for ourselves. I'm an interventional cardiologist. I've worked at the Alaska Heart Institute since 2005. The Alaska Heart and Vascular Institute was founded in 1999 on a premise of access to advanced cardiac care for all Alaskans, regardless of ability to pay. That premise rings true today. We treat all patients that come through our doors regardless of ability to pay. In fact, 60% of our patients that we see at the Heart Institute are government payers. The largest portion of that government payers are Medicare patients. We also see around 10% uninsured and a little bit less than 40% commercial insured patients. We are the largest outpatient non-native Medicare provider in the state. 1 in 3 Medicare patients who are Alaskans are seen and followed by the Alaska Heart Institute. We're in-network providers for all major payers. And although our costs are higher than the lower 48 for a myriad of reasons, our costs are lower than our Alaska competition. We compete with the acute care hospitals in South Central Alaska for invasive cardiac procedures. And we've successfully moved a large portion of our inpatient procedures to the outpatient office setting for a total savings to the patients and the healthcare system of 50 to 80%. We compete with 11 imaging centers in South Central Alaska for cardiovascular imaging, and our policy is to have the lowest price for all non-invasive imaging. The biggest problem we see in providing care in Alaska is a physician shortage for cardiovascular services. With Alaska's population of 750,000, by national standards, we should have 70 cardiologists serving our population. We currently have 32 cardiologists. 24 of those 32 cardiologists work at the Alaska Heart Institute, and those 24 docs are responsible for the outpatient management of the entire non-native cardiovascular population in the state. We provide 24/7 hospital call coverage in Anchorage and at Matsu Hospital. We supply backup and subspecialty coverage for all other cardiology practices in the state. And we provide 24/7 phone access for referring physicians and patients. If a patient shows up at 2 o'clock in the morning with myocardial infarction at any hospital in South Central Alaska, they'll see an Alaska Heart Institute general cardiologist within 20 minutes, and the artery will be open within 60 minutes. We have been trying to attract, to serve the patients of Alaska, we've been trying to attract additional cardiovascular practitioners to our practice for since it was founded in 1999. We've identified a need for at least 5 additional general cardiologists. And despite aggressive recruiting efforts for the past decade, we have been only able to recruit 4 additional cardiologists to our practice. And over that same time period, we've lost 6 to retirement or moving out of state. Over the next decade, we anticipate losing 11 of our existing 24 docs to retirement. And with the Medicare demographic, the fastest growing population in the state, our work is just starting to build. We recognize that we're the stewards of cardiovascular care in the state of Alaska, and we understand the gravity of our responsibility. We also understand the dire fiscal crisis affecting Alaska and the unsustainable rise in healthcare costs. We've initiated cost control measures to improve the efficiency with which we deliver care and disease management programs to improve the quality of care we deliver. We look forward to not only participating, but leading and finding solutions to our complex problem. Thanks.
Thank you, Dr. Watkins. Now we turn to a man who has written more than a dozen newspaper columns on this topic and hosted at least 2 radio shows on it, Charles Wohlforth.
Thank you for inviting me up, Cliff. I'm the only person on the panel who's not in any way involved with healthcare or healthcare regulation. And in fact, I've never found the topic of healthcare to be particularly intrinsically interesting. The reason I started writing about it was because it's very important and I think it's having a huge impact on Alaskans and our economy. The way I've tried to approach it is to try to simplify the question, because there are so many complex issues that can be thrown into the mix. And essentially what we do as journalists is follow the money and figure out where's the money coming from, where's it going. And so when you do that, and Dr. Groh has already made some of these comments, you can separate out some things. We know Alaskans don't have overutilization of healthcare. Our utilization is below average. We know that pharmaceuticals are super out of line in Alaska. Most healthcare in Alaska is delivered in Anchorage. The cost of living in Anchorage is lower than it is in Seattle. So why are the costs so much higher here? We also, the question of cost shifting is a big one. But you really don't have to worry about that if you look at it at a macro level. If you look at it as a per capita, how much do we spend as a totality for Alaska for all our healthcare and how many people live here? We still know we're off the charts. I divide causes into sort of two categories. One would be structural causes, which are about what our state is like and how many people are here and how small our communities are. And the other would be causes which are more into control of the political process and the fact that politically we've had no will to deal with this cost crisis. We've done a lot of stuff around insurance, but there's nothing done about cost from the political level. So in terms of structural things, small communities with 1 or 2 hospitals, with a few practices for each specialty. Frankly, we're never going to have, there's no way you'd ever have competition that would be vigorous like in another state, because you need more than 2 players in order to have real competition. So the lack of competition is a problem. And that's been addressed. But then in terms of how does that play out in terms of the political process, I think the 80% rule, which requires out-of-network, requires insurance companies to pay out-of-network 80% of the charge, usual customary charge, allows the specialty, that is the non-competitive practices, to charge essentially what they want. That's a rule that used to exist many places in the country. Now we're the only state that still has it. And that points to sort of a whole suite of regulations and laws that we have that other places don't have anymore. If you look at, it's not only that we have higher costs, it's that our cost has escalated faster than the rest of the country. And in terms of a goal that we would go for, if we could just have our costs escalate at the same rate as the rest of the country, we'd be better off, right? It'd be great to get down to the rest of the country, maybe that's not realistic. But elsewhere in the country, they no longer have fee-based services. They're doing value-based services. We don't have that in Alaska. In the rest of the country, they have managed care. We don't have that. In the rest of the country, they've gotten rid of the 80% rule. If you go out of network, you're going to get killed, so you don't go out of network. And that gives the insurance company the ability to negotiate a good price with your provider. Other states have gotten rid of the certificate of need law that we have, which allows hospitals to maintain a lack of competition. The U.S. Department of Justice specifically asked Alaska to repeal our certificate of need law last year because academic study tells you it causes higher prices, but we haven't done that. In fact, we haven't really done the most basic thing, which is we could go to our excellent social and economic research institution at the University of Alaska and we say, here's $200,000. Tell us why the costs are so high. We haven't done that. We've got a terrific scientist there who wants to do it. Nobody's paid to do it. I got to say, well, maybe we don't want to know, right? Maybe our power structure would just rather leave the situation the way it is. Hopefully that's changing. But we haven't done the basic things we could do. And then after that, we can maybe start thinking about the big things like the single payer, these other really difficult things that are much harder that would address some of those structural problems.
Thank you, Charles. Now we're going to go to someone who has observed this question of the state's high healthcare costs from a position as the state regulator. Wing-Heier is the director of the Alaska Vision Insurance. Wing-Heier, why are Alaska's healthcare costs so high?
Well, the cost of healthcare is not a new subject in Alaska. Our costs have been higher for years. As Dr. Hall talked about, I remember discussions on this on workers' compensation when I was a broker. And employers were very worried of how they were going to provide workers' compensation. But we have just started the conversations on healthcare. Recent efforts the Work Comp Board has made a difference in workers' compensation. But again, the conversations on healthcare specifically have just started. Access to healthcare is essential. There's not a one of us that will go through life without needing it at some point in time. Moreover, we want it to be the best. No one wants to send a family member to a doctor that gets, or a facility that gets 1 star on Yelp. And there's a cost to having the best. We want it to be convenient. We don't want to go back to perhaps the way we were in the 1980s or earlier, when the majority of healthcare was performed in Anchorage, and people traveled great distances to receive healthcare, making us look more like a third world country than Alaska. The size of our state does present some very unique challenges. We're a large geographic mass with limited facilities. We have a small population, and we're fractured. We're fractured in the fact that we've got Medicaid, Medicare, VA, TRICARE, commercial insurance, and in that, we have self-insured, small group, and large group. We're paying for health care in a variety of ways, and yet we think that if we went to a single payer or some other common mechanism, that the cost would go down, and that's not necessarily true. There will always be a cost to health care. How we fund it is the conversation. We should expect to make some changes in how we access care. Looking much like ENTHC has done and looking at the whole person in a holistic manner, reviewing value-based payments, education on the role of primary care and on the role of emergency care, telemedicine. These discussions are starting to happen and we're starting to see some results, but it's going to be a slow process. We expect it to be affordable, but yet how many of us grew up in a home or in our own home thought once the deductible was paid, particularly on employer-based plans, that health care was free? We weren't using our health care smart. This is going to take time. This is a system that's been around since World War II. So we need to come up with solutions that are not biting out small chunks at once, but look at what we're going to be at the end of this process. Because if we do little small bites at a time, we could be worse off than when we are. It's probably a bad analogy, but when Costco came to Alaska, it changed the way we buy groceries and it changed the way we buy household goods, but it didn't necessarily drop the prices at Fred Meyer's. It just made us think about it. And it made us think about the way we purchase and how we're spending our money. So tonight's conversation is not just the cost of healthcare, but it's what do we want and what do we need? Do we want it to be convenient? Meaning, do we want the facilities here in Anchorage? Do we want facilities in Seward? Do we want facilities in Fairbanks, in Ketchikan, in Nome? Because there's a cost to having those facilities with a very small population and recruiting people to staff those facilities.
Thank you, Lori Wing-Heier. Now we turn to our final panel to Jennifer Meyhoff, who's the legislative co-chair of the Alaska Association of Health Underwriters. Jennifer Meyhoff, why does Alaska have such high health care costs?
Well, the advantage of being at the end of the road here is that a lot of the conversation has been addressed, but I'm going to focus from a different perspective a little bit, which is, for one, I'm a lifetime Alaska, that's not unique here, but I'm proud of it. And I've been in the benefits consulting business for over 25 years. So I help employers figure out what kind of employee benefits they can offer to their employees and what they can afford to offer, what they want to offer, and what that looks like as they make those choices. And if you'll indulge me, I'm going to try to read mostly so that I don't miss anything. I promise I won't read if you ask a question. So I over my years as a consultant, I've educated employers and all kinds of ranges of employee benefits services. Short-term counseling for employee mental health needs, medical plans, dental, vision, life, disability, all kinds of benefits that an employer might want to offer to their employees. Really over that time, I have seen so many changes in Alaska, but part of what I've also witnessed by virtue of being involved in some larger national organizations is changes that have happened in the lower 48 that haven't happened here. Really what I saw and what I remember is really in the 90s, early 2000s, prices were kind of spiking everywhere to buy medical insurance in particular, or medical care. And what happened by about the mid-2000s is prices or trend increases started lowering a bit. And what it turned out to be, much of what was driving that nationally was the directed care, so HMOs, managed care, those kind of things that were mentioned, but are not allowed in Alaska. So really by the mid-90s or mid-2000s, lower 48 was starting to trend down. Alaska was not trending down at all. We were continuing to trend up. And really, I work with employers large and small, so I mean, I've seen this across the spectrum of employers trying to offer services. We've seen very little coordination of care ever. I mean, we're Alaskans. We grew up being told we can go to wherever we want to go to. Don't tell me I have to go to a primary care physician before I go to see ear, nose, and throat guy. If I want to go see him, I'm going to call up and I'm going to go see him. Even though maybe I could receive just as good care from a non-specialist that provides great service at a lesser cost. So that's been a fundamental core of who we are as Alaskans, and we like it that way. But that can make an impact in terms of the lack of coordination or appropriate levels of care. Many of my employer clients are self-funded, so I have clients that purchase medical care on the market with 2 carriers, fully insured plans, but I have many employers that are self-funded. So I actually see what kind of claims are coming through. And that's where we really start to see some real differences. One piece would be medevacs. And many of you in the room may have experienced or heard stories. If you're in the North Slope, if you're in Barrow or Dutch Harbor, you need to be transported to Anchorage, or let's say Anchorage to Seattle, it easily could be $125,000 for a one-way flight for one patient. Amazing, amazing. Lack of transparency has been a real challenge, and this year, many of you are probably aware the municipality of Anchorage passed the ordinance that will require some transparency within Anchorage. So that's one piece of the puzzle, and we'll see if that makes any difference. It affects just Anchorage. And the unique item in Alaska, as we mentioned a couple of times, is the 80th percentile regulation. So really, that was originally provided to, or put in place as a protection for patients, so that they wouldn't be billed from the providers and also weren't covered by a plan. Really, the unintended what it did is it mandated that carriers to pay for out-of-network providers at the 8th highest bill out of the 10 bills for the same procedure. So in other words, you have 10 bills come in, that carrier has to pay at the 8th highest amount. And that amount is updated twice a year, which means the rates continue to go up without a cap, but it has a floor. So it brings the water line of all those charges up, particularly for out-of-network providers. The unintended consequences is because there's no cap, then the prices still go up, and then patients can still be balance billed for the amounts that weren't paid to that provider. The overall cost, I know my time is getting up. The last couple things I want to just mention briefly is many of you may have heard Milliman, the independent actuarial consulting firm, did a study, the Alaska asked for the study in 2011, and then they updated it in 2016, comparing commercial healthcare claims and payments in Alaska versus other states in comparable areas in 2011, but then all across the nation and in specific areas more broadly in 2016. The key findings of the most recent Lamoureux report was that provider payment levels in Alaska are 76% higher than levels nationwide. Physician levels are 148%